Welcome to the Health 210 podcast. Today we have with us a trusted GI specialist. He's known for his clinical excellence, approachable style, and genuine patient care. Please welcome the amazing Dr. Alvarez.
Oh, thank you. Thank you for having me, guys. I appreciate it.
Yeah, really appreciate you taking our time. If you could start off with your story,
Sure.
what initially inspired you to pursue medicine and then eventually be a GI specialist.
Okay, yeah, definitely. Initially, my dad he's a nephrologist in El Paso, and
Cool.
I grew up in El Paso, born and raised. He was never home because of his job.
Yeah.
He's kind of the old school, right? And so it actually kind of made me not want to become a doctor, kind of growing up. It wasn't until kind of when I was in high school, college, that I started shadowing some of his colleagues
Yeah.
in internal medicine. Saw really basically kind of what they did, what they were doing for all their patients. And
Yeah.
kind of I understood why my dad wasn't around. It was,
Yeah.
I mean, he had to make sacrifices as a physician
True.
for the greater good,
Yeah.
right? And so that was kind of a turning point for me in understanding what a physician does.
Yeah.
And so that's where I decided, hey, I think this is for me.
Yeah,
Yeah,
yeah, cool. Yeah, it's amazing how, right, like at one age, your parent being away kind of puts you away from that profession, but then when you realize, what they're doing and, what it means and what the impact is, you like it.
Absolutely.
So where was your training, like, med school, residency, fellowship, where did you train?
So I went to college here in town, Trinity University.
Okay.
Didn't do the greatest coming out, so I went home, started working for the medical examiner's office, started working on getting my master's in public
Nice.
health to get into medical school. So finally got my master's, applied to medical school, got in here at UT Health Science Center in San Antonio.
Nice.
This was from 2008 through 2012, and then did residency here. And then I went and did my fellowship in GI at Scott and White in Temple,
Okay.
Texas.
Oh, cool. Very
Yeah.
cool. And day in and day out, like the scope of your practice these days, what are some of the common conditions that you're treating, and what part of gastroenterology you like to focus on?
So my focus, I did an extra, well, in a way it was an extra year, but at my fellowship, it was put into the third year of our fellowship, right? And so I focused mainly on advanced pancreatic biliary kind of disease states. So we do a lot more procedures with EUS, endoscopic ultrasound,
Okay.
and ERCP, and really it's more of a therapeutic way to treat these disease states. And so that's where I focus on, and that's where my love really is for, in GI, but we have such a broad scope of practice within GI, general GI,
Yeah.
in treating different disease states, functional disease states like IBS, dyspepsia,
Yeah.
GERD, Barrett's esophagus, chronic diarrhea, which, there's a whole lot there to
Yeah.
kind of unpack.
Yeah, and those are some of the common things that we see at the primary care level, right? A lot of
Right.
people coming in with, heartburn or
Right.
abdominal pain, gastritis, and
Right.
some of them are like very easy to treat and they respond quickly, but then there are some complicated cases that need the GI expertise. When working with different primary care providers, do you see a pattern, or would you expect or want things to be done differently? Like, at what point do you think someone with chronic diarrhea, let's say, or acid reflux, do you think warrants like a GI eval?
You have to go through internal medicine to become a GI doc, right?
Yeah.
And so I know what you guys encounter day in and day out, right? And so you have the knowledge and expertise to treat reflux or heartburn. It's just kind of run of the mill, right? And what you usually do is just give them acid reducing medication.
Yeah.
And educate the patient over really how to take it, when to take it.
Yeah.
And if you're not getting the response that you want with that medication or that treatment, and they're taking it appropriately, that's when you would refer to GI to say, hey, there may be something else going on here.
Yeah.
Chronic diarrhea, that's also, that's a lot to unpack. Like I was saying before, most of the time you can run an infectious stool panel if it's more of an acute issue.
Yeah.
Meaning within 2 weeks.
Like there's a bug or something that you
Correct.
can treat, and that should go away.
And it's kind of in the community kind of deal. But if it's something that's kind of more of a chronic issue, more than 4 weeks, then that's something that you may want to push off to GI to say, hey, this patient may need a colonoscopy, or other sort of studies to figure out what's going on with the chronic diarrhea to get that under control for them.
Absolutely.
Yeah.
So with your focus on the advanced GI side of things, so primarily y'all do what's called ERCP, right?
Right.
So can you talk a little bit about, how that's done? Because, a lot of our audience may not know.
Right.
And then some of the common conditions, I know, if there's like a gallstone stuck in the biliary system, that can be taken out.
Right.
So a little bit about that too for our people.
Right. So, I mean, it's very common, especially in our community, right?
Yeah.
I mean, we see a lot of gallstones, and more about 70% of people are walking around with gallstones in their gallbladder, and they're not symptomatic. But the day that they become symptomatic is because that stone that's made in the gallbladder pops out into the bile duct, and it basically blocks up the little hole where bile drains out of into the small intestine. That causes a lot of pain, and then that's when they want to go, get that addressed, usually at the hospital because the pain is so severe.
So severe, yeah.
Right. Can lead to an infection, that can lead to an infection in the blood.
Yeah.
And then they can get really sick from that. So that's where we have to intervene with this procedure called ERCP. Really, that's what we do is we use endoscope where we go in through the mouth, into the esophagus, into the stomach, and then to the first part of the small intestine called the duodenum.
Yeah.
There's that little hole that I was talking about.
Yeah.
We look at that area specifically, and then we try to get into that hole, make an incision there, and then we stick a catheter into that bile duct. That catheter has a little balloon at the end of it, and so we blow up the balloon, we get past that stone, and then we pull that balloon down and sweep that stone out.
So kind of almost like unclogging a drain pipe, right?
It's basically
it's just having it at a very small microscopic level, or not microscopic, very very minute.
Absolutely,
so that's cool. Yeah, very cool. And let's talk colon cancer, right? Because that is a very important topic. We've seen some changes in the guidelines.
Mm-hmm.
Now people are advised to screen starting at 45 instead of 50. What do you see in practice, and what do you think is causing these early onset cases of colon cancer?
Yeah, it's a scary thing because we're seeing younger and younger folks with colon cancer popping up, in their 30s.
Yeah.
And it really, pushed me to get my own colonoscopy early on.
Early on, yeah.
Yeah, and so.
And same here, I've done it. So.
Right. Yeah, and so it's in terms of what's causing it, we really don't have a good grasp on that yet. Understanding that obesity, because in the United States, obesity is an epidemic, and so that's one risk factor for it. In addition to what I believe is really processed foods, ultra processed foods, that's really I think partially driving it as well. In a way, smoking, red meat, those things will.
Yeah, because if you think about our food chain and all the stuff that we're exposed to, it's so hard. Even if you try to go whole foods and all natural, I mean, you just go back and see, it's very hard unless you go and like grow your own stuff in your backyard.
Right.
It's technically very hard to do that.
Absolutely.
I want you to talk about how impactful it can be if you detect colon cancer early. Because we've seen cases. I've had personal family experiences where it devastates the family, right? And what we try to educate our patients is, this can be such a turning point. If you get that early detection, what do you have to say about that?
Yeah, I mean, it's so important for screening. I think there's a lot of stigma around colonoscopies.
Yeah.
Having to go through, your bottom to figure out what's going on. But it's really changed in terms of, how we do it nowadays. It's much more easy and comfortable for the patient to go through. We use a lot of different medications than we did back in the past. We use propofol nowadays to where the medication we give is quick on, quick off. So basically within 10 seconds you're asleep, you won't feel anything, you won't know what's going on.
Yeah.
You get through the procedure, it takes about 20 minutes, you wake up, you feel like $1 million.
Yeah.
And it's because of that medication. But really the issue is with regard to early detection is if we catch it late, it's very difficult for us to treat.
Yeah.
And the mortality rate is much higher, meaning that you have a much higher chance of dying.
Yeah.
Despite undergoing treatment.
Yeah.
But with early detection, it's much more treatable, less morbid, meaning that you won't have issues with potentially getting a bag, an ostomy bag, rather than going to take out the cancer early on, surgically, maybe getting chemo, But it's very curable
Yeah.
if we catch it early.
Yeah, yeah.
Yeah.
So that's important, right?
Absolutely.
And it's a slow growing cancer typically, right? That's why I mean the screening intervals are so far apart that if you have a normal colonoscopy,
Right.
typically you all say you're good for like 5 to 10 years.
Correct.
Any thoughts on that? Like how frequently one should get one?
Well, yeah. So I mean, starting at 45 is where we
Started.
Yeah. So we used to be at 50 as the age to start, but now seeing that we're getting colon cancer at younger ages, we pushed up that age to 45. So I mean, in terms of the risk factors for even earlier than 45 are family risk. I mean,
Yeah.
family history.
Yeah.
So if you have a family member that had a colon cancer under the age of 60.
Mm-hmm.
So you want to be able to get that colon screening done at least 10 years before their diagnosis.
Yeah.
And that's in a primary first-degree relative.
Relative, yeah.
Second-degree relatives, not so much, but it does matter in a way to us. But, we still keep you at the 45 age screening limit. When we talk about the reason why we do these, I get a lot of people that say, okay, well, I know we're doing this for screening purposes, but what are these little polyps that you talk about?
Yeah.
And they're little growths.
Mm-hmm.
Those little growths are what can turn into cancer, and it takes about 10 years for that little polyp to grow into cancer.
Yeah.
Not all polyps are precancerous, but if we see them when we're in the colon, we'll remove them and send them off to the lab, and the lab will analyze them to see what types of polyps they are.
If they're high risk or lower risk, right?
Yeah, there's different types of polyps and different risks associated with these polyps with regard to the risk of cancer if you leave it alone in the colon. And so however many they have, how big they are, what type they are, dictates when we bring them back for their surveillance colonoscopy. And so it could be anywhere from a year. So if you have more than 10 polyps, it's a year. If you have anywhere from 3 to 10, it's going to be 3 years.
Okay.
And then 1 to 2, it's usually 5.
So complex
to 7.
decision where it involves multiple things. The number, the size, the type. So again, important thing is you want to get your colonoscopies done, and then follow the screening interval and guideline that's recommended. Right.
Right.
Another common condition that we, at least at the primary care level, see a lot is chronic constipation and then some associated hemorrhoids, right? Yeah. So at the primary care level, we can treat it with medications, and a lot of those respond.
Right.
At what point do you think it warrants GI eval for intervention, and what modalities y'all have?
Again, kind of going back to like internal medicine training, it's really a simple fix early on is more fiber in the diet, more water.
Yeah.
Those two
just
together.
Don't get constipated, right?
Right. I mean, make sure that you're hydrated and you're taking enough fiber in your diet. If you can do that, more fruits, more vegetables, what you're trying to do there is soften up your stool.
Yeah.
And by doing so, you won't be straining. If you're straining, you're pushing these hemorrhoids out, and hemorrhoids, all they are thin-walled veins, and at the anus. And so, if you're straining, you're pushing out these hemorrhoids, and they get engorged with blood. They can bleed. They can itch. They can be just a nuisance.
Yeah.
And so, it's a pain really for patients, and it can get really bad to the point where they're protruding all the time, and at that point is when you should be sending the patient to GI, but really, starting off with conservative measures with these things that I was talking about: fiber, water, a fiber supplement. Really, for people that don't like fiber,
to get it like naturally for their diet, or just can't get it because of their dietary patterns.
Right. Yeah. So Metamucil, Benofiber. There's all sorts of different over-the-counter fiber supplements that you can get. HEB, Walgreens, Walmart, anywhere. Yeah. And start taking that once or twice a day, and you'll notice difference. Main thing with that is being consistent, because people will start taking it for a period of time. I feel better, and then they stop taking it,
and then it's back.
And then it's back, And so really, it's making sure that you educate the patients over, hey, you got to continue to take this. There's no harm in continuing to take it. Yeah. It's just, and there's a adjustment period with your body. Mm-hmm. There may be a little bit of time where you get a little bloated. Yeah. Because of the fiber for maybe a couple weeks, but really you have to ride through that.
Push through it, and
then after a while, your body adjusts to it, and then you start feeling or noticing the difference.
Yeah, that you got to adjust. Cool.
Yeah.
So, Dr. Alvarez, we very commonly encounter these patients who will not agree for a colonoscopy or just don't want to get it. Is there any alternative for them to screen for colon cancer?
So there are a few. I mean, there's a lot of patients that don't want to undergo the actual procedure or sedation. There's Cologuard, there's a FIT test, there's a fecal occult blood test, but most recent one that that a lot of people ask about is Cologuard.
Yeah.
And Cologuard, it's a good test. Really, it's testing for blood in the stool and then some DNA assay. But basically, it's a test that you take at home.
Okay.
And you send it off, and they basically tell you if it's positive or not.
Okay.
The problem with, I like it, and, I kind of have a love-hate relationship with it because, for people that don't want to go down that route, this is a good alternative. It does have a false positive rate of about 13%.
Okay.
So, the issue with that is if, it does pop positive, you have to get a colonoscopy at that
anyway,
point. Right.
Despite that.
Yeah, just because at that point we're thinking that you got colon cancer. The patient thinks that they may have colon cancer as well. And so that time period,
undue anxiety and stress.
Exactly.
Right? Yeah.
Exactly.
Because they almost, I get it. They almost take it like, okay, something's wrong.
Yeah. And so at that point, a lot of times you'll come to me with that test. I'll do the colonoscopy, and I think maybe I could count on both hands. Maybe once I've got maybe one colon cancer out of all the Cologuards that have come to me.
Okay.
Yeah, and so it's not a lot of patients that have actually colon cancers. They may have high risk polyps, but really it's one of those things that that's what I was telling you about the love-hate relationship. It definitely will bring you to me if you have fear of doing the colonoscopy, but then you have this undue stress kind of on your shoulders, and it's more of a burden at that point.
So maybe better than if you're not going to do anything, might as well do that.
Absolutely.
But still nowhere close to what colonoscopy gets you in terms of proper screening.
Yeah, colonoscopy is great just because it's going to pick up small little polyps.
Yeah. And
these small little polyps do harbor a risk for turning into cancer with time. These other tests won't pick that up. And so, and then you can't remove the polyps with these tests. I can't.
Yeah. You're already there. Might as well just, take care
And so
of it.
I'm giving you more reassurance after the fact. Say, hey, look, if you had a good exam and your colon was cleared with the prep that we gave you.
Yeah.
And I'd say, hey, look, I took out all the polyps. I'm going to tell you you're good for another, 5 years or 7 years or 10 years, whatever.
Perfect.
And so that gives you a lot more kind of peace of mind.
Yeah.
In the end, rather than doing a Cologuard every 3 years is what's recommended for a Cologuard, and that's only in a screening setting.
Yeah.
If you have a history of colon polyps, then you should not be doing Cologuard. Yeah. It's not indicated at that point.
Okay. Yeah. Perfect. All right. So still, get your colonoscopies, right?
Absolutely.
That's the message.
Yeah.
Okay. So moving on to another common complaint or disease process that we have related to the GI tract is IBS or irritable bowel syndrome, right? Can you talk a little bit about that, the causes, and how can people commonly manage it, treatment?
Pretty prevalent. I think out of all the conditions I've seen in my office, IBS is probably up there.
Yeah.
So IBS, irritable bowel syndrome, is basically a hypersensitive gut. So the way that we define it is basically abdominal pain that's really associated with alternating diarrhea or constipation, or you may have one predominant symptoms, meaning IBS with diarrhea or IBS with constipation. But basically, it's something that is very common. And again, a lot of that has to do with diet. And I explained, that to most of my patients is really, that's one of the first questions I ask is, well, tell me about your diet.
Yeah.
And they tell me, well, I eat out a lot. I don't eat the best.
Yeah.
And so, really, the treatment for IBS or our gold standard for that is what's called the low FODMAP diet. And what that is you got these short chain sugars and everything that we eat, but those little short chain sugars we're not able to break down very well. And so what happens is they pass through the gut into the large intestine, where a large majority of a microbiome, which is the bacteria that live in our gut.
Yeah.
It's a community of bacteria that live in our gut. They get to it. And there's good and bad bacteria that live in there, and really the bad bacteria get to these short-chain sugars. They metabolize it, produce methane gas. They can produce these fatty acids that can draw water into the colon, cause diarrhea, cause bloating, pain, those things. And so what we do is remove those from the diet, and basically you'll notice a big difference.
Yeah.
And we remove it for about 6 week period of time, 6 to 8 week period of time, and then we slowly introduce those foods back into your diet to see, can you tolerate them with time.
Okay.
Yeah.
Yeah. And then you can use like medications to help with the symptoms in the meanwhile,
Absolutely.
right? If they're having a lot of diarrhea, you
Yeah.
can use some agents to slow down the gut.
Right.
Alternatively, for constipation, you can use some laxatives
Right.
to relieve the symptoms.
Right. So I mean, there's medications like dicyclomine, bentyl that are antispasmodics. You know, that crampy pain that comes along with IBS. We're able to stop that with taking these medications. There's medications to slow down diarrhea and to also improve constipation. Those are Band-Aids, really, in a way, but, you know, they do help, you know, to get you over those severe symptoms when they come on.
While you're managing it.
Right, but really, exactly. It's really kind of changing the lifestyle in a way to help improve IBS.
So you mentioned an important thing there, like, you know, they have a hypersensitive gut. We also see a lot of GI symptoms, you know, people suffering with, like, you know, mental health issues, like depression, anxiety. We kind of see that. Is there a correlation between, you know, these mental health problems and how their gut responds to it?
Right. Yeah. I mean, there's a gut-brain connection that we usually talk about, and it tends to, you know, one tends to influence the other at times, and so, you know, you have some sort of mental health condition that can lead to some gut issues and vice versa.
Yeah.
And so, you know, a lot of times we can give medications like antidepressants that will help at a lower dose in a way that will help really both conditions. But there's some medications, neuromodulating medications that we can give to decrease the amount of pain that they're experiencing with IBS.
Yeah.
But these are antidepressants, so we increase the dose that could also
help with their mental health.
Correct.
Yeah. So again, I mean, you know, important to take care of your mental health because there's a strong gut and, you know, brain and gut connection, as you talked about.
Yeah.
You also talked about the microbiome there, right? So that's another very hot topic these days.
Yeah.
What's your take on, you know, the gut microbiome and what role it plays in your overall wellness and you know, different disease processes?
So I mean, I think I tell people this all the time. We're kind of at the tip of the iceberg with that. You know, I think we're still very early on in terms of our knowledge with regard to the microbiome. We know that it does influence various aspects of our health. Initially started with obesity, but now we know it reaches into different areas like cardiovascular health, cancer risk.
Yeah.
In terms of in terms of the gut health, it's something that we're learning about. Figuring out how do we manipulate the bacteria that live in our gut to help improve these conditions that we have.
To actually have some positive effects,
Right. And so probiotics, we're learning, have some aspect in it, but we still don't know, what's the best probiotic out there. Very, very, very little literature to say that probiotics really help.
Yeah.
But, what I tell people or patients all the time is that if it works for you, then use it. But, but I usually say give yourself a good 3-month trial on it, and if you're not getting any improvement, don't throw your money away.
Don't spend on it.
Yeah, because they cost anywhere from $30 to $80 a month that you're spending, and so. But I mean, there are some that people come back to me and tell me, "Oh my God, my life is completely changed." And I say, continue it.
Yeah,
absolutely.
So you probably I guess the idea is that we know some, but there's a lot more to know about this to exactly come up with like treatment plans for certain diseases and how it can help in different processes.
Right.
But I guess for the general population, if it's something that they do in consultation with their physician, where it's not something that would cause harm, it's worth a try, and they can explore it. If they get some benefit from it, great, why not? But
there's no real downside to it.
Yeah, perfect, cool. Is there something that you're looking forward in GI, something new coming up in terms of like treatment modalities or procedures or anything exciting these days?
Yeah. I just did the other day in my endoscopy center. We did what's called it's AI basically, and so it's called GI Genius through Medtronic, and so we're using AI when we're doing a colonoscopy to help us figure out or see areas that the naked eye may not be able to see.
Oh, wow.
And so it's pointing out areas of interest that may say, hey, there's a little polyp there.
Okay.
Or, there's something else that you may need to take a closer look at.
Cool.
And so it'll focus on that area. And so we go look at it, and we can look at it in different kind of light, narrowband imaging that tells us kind of a little bit about the pattern of the lining.
Nice.
But all that, is something I think that's going to help, going back to what we were talking about with colon cancer risk, it's going to help us decrease the risks or catch colon cancers, polyps earlier.
Even earlier.
Yeah.
Right. Yeah.
Yeah.
So it's basically kind of acting, so AI in the gut right now is helping you see better,
Absolutely.
to put it that way. So
it's a second set of eyes.
Yeah.
It's amazing to see that, we're there in 2025, and there's downsides to it because it's an algorithm that it's gone through millions of pictures of polyps, and it's just able to recognize different things, but sometimes it overcalls, and so then that slows us down a little bit.
And then that's the technology, right? It will get better with time.
Absolutely. Yeah.
Cool. Now coming a little bit, outside the work life, a little bit on your personal side, what interests you outside work, or what kind of keeps you motivated or keep you grounded to kind of keep doing all the work that you're doing?
We're inside all the time. We don't have windows where we work usually.
Yeah.
And so it's nice to be outdoors, right?
Yeah.
And so for me, I like being outdoors. I like doing stuff that is non-medicine related. I used to in college and beyond that, I used to watch these medical programs on TV all the time.
Yeah.
Now I want nothing to do with medicine outside of it. Yeah, absolutely. I don't want to watch it on TV, and I just want to be doing something else.
Yeah.
And so for me, exercise, it helps to just give me energy because how much we work, right?
Yeah.
We work, long hours, and it can be debilitating kind of on our health, on our mental health as well. And so for me, exercising regularly, I try to do 3 to 4 days out the week.
Cool.
And then, the other part is just really hanging out with my family. My kids are big in my life, and really that's it, man. Work and my kids and working out really takes up all
everything.
my time.
There's hardly anything to squeeze in there, right?
Yeah.
And I was reading a survey where they asked physicians what they do to kind of avoid burnout.
Yeah.
Exercise was on top, like about 52%.
Absolutely.
49% said spending time with family.
Yeah.
The next one was sleep. Those
Sleep
who can get it.
Sleep is necessary, but there's always a trade-off there. If you want to work, for us, we work all the time. My me time is usually early in the morning.
Yeah.
Right. 5, 6 in the morning. That's when I can work out. But the trade-off there is a little bit of sleep.
Sleep, yeah.
But you need sleep.
Yeah.
Right.
Yeah.
And
so you just kind of get as much as you can that makes you stay functional and active, but you got to squeeze in other things.
Yeah, I catch up sleep on the weekend. Yeah.
So while we're talking about colonoscopies, I think what can help a lot of people who are kind of on the line and hesitant to get one is to know from someone who does them day in and day out, right? What does the process look like? So I know we send a referral. Your office contacts them and they get this prep, right? So the night before they're supposed to do that. How cumbersome is that, and how does the day of the procedure look like?
So it's a process. So usually, you either meet with us in clinic and I talk to you about the process, or you go straight to the procedure, just depending upon your history, right?
Yep.
So if you have a long laundry list of medical conditions, heart disease, kidney disease, anything that's going to cause problems potentially when you undergo sedation, well, I'm going to see you in clinic first.
Yeah. Or even blood thinners, right?
Blood thinners, absolutely. And so, but if you have no problems, then we'll get you set up and you go straight from, that referral into the procedure. So what we do is we call you, we say, okay, well, you're going to be getting a colonoscopy prep, which is really a laxative. Yeah. A laxative that makes you just poop your brains out. Mm-hmm. And so the day before the procedure, you're going to be on a clear liquid diet, or just liquid diet in general. So that means thin liquids, Gatorade, water, tea, black coffee.
Nothing solid.
Nothing solid, no shakes, nothing like that. The most you could have really is Jello, broth, is what most people eat or during that time, just kind of stay hydrated. Yeah. And so You do that for the 24 hours before the procedure at about 5 p.m. So we have a split prep now. It used to be you take your whole prep at 5 p.m.
Yeah.
But split prep gives us a better look at the colon, meaning that it's a cleaner exam.
Okay.
So we give half of the prep at 5 p.m. and then I have to torture you a little bit and give you the other half at 3 a.m. The morning of the procedure.
Early morning.
Early morning of. And so basically, that's the hardest part.
Yep.
That's why I tell people.
Just staying up all night, in the restroom.
It's stressful. Yeah, you're between the couch and the toilet pretty much, the whole night, right?
Yeah.
And so, and that's, it's part of it, but, I think it's a part that's very necessary for us. For me to give you the best exam, the instructions on how to take that prep are very important.
Yeah.
And making sure that you don't eat.
Yeah, and also you don't want to go and do it again, right? So, do it the first time.
Do it right the first time. And we know if you cheat, too. Some people will say, well, I didn't eat, and they really did.
Yeah.
Well, I'm going to know because I'm in your colon, right? And so, don't eat.
Yeah.
That's all I gotta say is don't eat because we know.
Yeah.
And so, that happens. Then morning of, you could have maybe sips of water with medications if you have to take medications like blood pressure medications. We give you instructions on if you are taking a blood thinner to not take it for a certain amount of time
before
the procedure. And then you need someone to drive you home. That's pretty important. You can't drive home from the procedure.
Yeah.
Because we give you sedation.
Yeah, so the medication is still wearing off while you're, throughout the day.
And so you'll have someone that'll drive you there and take you home. But basically, you get there to the endoscopy unit. You'll sign some paperwork. They'll put in an IV, and then they'll get you in for the procedure. The procedure itself is a breeze for the patient. Basically, it takes about 15, 20 minutes max. And again, they're asleep for the whole procedure. So there's no tubes breathing for you. It's like you're taking a nap.
Yeah.
And so
there's no breathing machine, no tubes going, all right? Perfect.
Right, yeah. And so it's like you're unconscious taking a nap.
Yeah.
So you have a team of people that are taking care of you during that time. You got a physician, you got usually a CRNA that's giving
anesthesia,
which is a nurse anesthetist. They give you the sedation, which we talked about is propofol. And so with that, they're monitoring your vitals during that time. So we're watching everything to make sure that you stay alive.
Safe,
that it's safe. And so then you have a tech that helps me out with whatever I need done. So if I got to take polyps off, they give me a snare, which is what we usually cut the polyps off with, or biopsy forceps.
Yeah.
If there's bleeding, I can cauterize things, but really that's their job. Then I got a nurse in the room that's really kind of recording everything or giving medications if they need to.
What's happening?
And so really that's it. And the whole process is in and out.
And then you just wake up in recovery, and then in a little while you get the results, and then you're good to go home.
Yeah. So afterwards we wheel you to the post-op room. Again, it's quick on, quick off. So once we stop giving you the medication, you wake up pretty quickly.
Yeah.
After the procedure, I go talk to you about the results. If I take off polyps, we usually send them to the lab, and then we either send you a letter that tells you what the polyps are. If there's something serious, usually I'm calling you or bringing you back to the office to talk about it. Yeah, but usually that's how it goes. And
So I guess if you were, for the people, like from a scale of 1 to 10 in terms of, how bad this is, the day before, the night before is probably bad, right? Or say like maybe 8 or 9 in terms of discomfort, but the day itself is pretty straightforward.
Oh yeah, I mean the prep itself, and having gone through it myself, usually I tell people I've gone through it too.
Yeah, so I know exactly what it is.
I know what you're going through. That's the toughest part, and there's different preps out there. You could talk to your provider about. It used to be just one prep called Go Lightly.
Yeah.
And it's not Go Lightly at all because you're going a lot. And so, but there's different preps like Movie Prep, Plan View. There's Sutab, which are little tablets. These other ones that I'm talking about, Go Lightly is really a gallon.
Yeah, large volume, right?
Yeah, large volume. And so, but the other ones that I'm talking about are really half that amount, and they actually have some flavor
in it,
to it. Which helps some, but it's still not the best. And then these tablets, if you can't really tolerate the liquids, it's a lot of tablets, but it's a different way to take it.
Get it done.
Yeah,
okay, cool.
yeah. So
perfect. Yeah.
There's that's the worst part about it. But the actual procedure itself, I'd say 2-3.
Yeah,
max.
not too bad.
Yeah.
Cool. All right. Useful information. again, I mean, can't emphasize enough, you're hearing from, the specialist himself, get your colonoscopies, right?
Absolutely.
So Dr. Alvarez, where can people reach you if they want to get, GI care, if you can tell about
Sure.
your clinic locations and where you practice?
Right. So yeah, we have 3 clinics. Where I practice at 2 Stone Oak and Sonterra is where one of my offices is at, and then the other office where I'm at is Babcock and Medical.
Okay.
And so that's where I do my procedures. I'm usually doing procedures Tuesdays, Wednesdays, Thursdays. Tuesdays I'm at Stone Oak. Wednesdays and Thursdays I'm in the medical center area. Afternoon is really reserved for clinic.
Yeah.
So I'll see, whatever, we've talked about all these patients with IBS, GERD, whatever it is I need to see you for, I'll see you in the clinic setting.
Okay.
And then Mondays and Fridays I'm at the hospital.
Cool.
Yeah.
All right. Well, I can't thank you enough for taking our time and doing this for us. It was amazing getting all the information, and we'd love to have you again on the show in the future. So thank you again.
Awesome. Thank you for having me. This was fun. Appreciate it.
Cool.